I would like to introduce Evan Klein. Evan Klein serves as a special assistant for legislative and policy affairs at HCA. Within his role, Evan manages the agency's state legislative relations and supports the agency's work on various healthcare cost-related policies and initiatives. And prior to joining HCA, Evan spent over 6 years as a nonpartisan staff to the State Senate Health and Long-Term Care Committee, as well as time as a senior policy analyst for Washington's Health Benefit Exchange. Thank you for being here today, Evan. And also presenting today, Ariel Pertek, Ari. She is a senior policy analyst for eligibility policy innovation and community support and has worked for the Healthcare Authority for over 10 years. Within her role, Ariel supports the agency's work in development and implementation of Medicaid and CHIP eligibility policy changes from the state and federal levels. We really appreciate you both joining us today and bringing your expertise and sharing that with us. Please go ahead.
Thanks, Lana, and thanks everyone for letting us join you today. We only have a little bit of time and a lot of material to cover. I think first want to just clarify, no conflicts of interest on behalf of Ari or I. Obviously, kind of just speaking on background related to some of the federal changes that are occurring to the Medicaid program. As Lana mentioned, I am joined by our senior policy analyst for eligibility policy and innovation. Ari, who's going to speak in detail to some of the major eligibility changes that are going to be occurring to Washington's Medicaid program and Medicaid programs really around the country. And then I'm here to provide a little bit of additional background on some of the other changes that we are looking to from the federal budget. I think, just want to highlight maybe at the outset, because I think that the relevancy is important. I see a lot of folks who are participating in public health, a lot of Western Washington providers, providers from impacted communities from the recent flooding, just acknowledging, I think now, we've been hyper focused on impacts of the federal budget throughout the summer, budget that passed in July, and sometimes kind of get disconnected from the relevancy of, how is this going to impact all the people that we serve? And, it's, as pressing as ever, I think this week and last week, seeing folks that are impacted in communities around the state from the flooding, need medication management, need access to providers, are struggling to reschedule, services, and that connectivity to the App Health program, the services that we can provide as an agency that some of our partners, like our managed care organizations, provide when someone is enrolled in coverage, really help hit home some of the importance of the work that we're trying to do really to mitigate the impacts of some of the federal changes on Washington's health coverage landscape. So just want to kind of acknowledge that as the backdrop. For background, I imagine much of this group is familiar, but there was a federal budget that passed in July of this year that made some significant changes to really the direction of how the country is thinking about health coverage. I think for years, much of our focus and emphasis had been on how do we bring down the uninsured rate? How do we expand access to health coverage? Obviously, the Affordable Care Act was a major milestone to that, well over 10 years ago. This direction from the federal budget is really changing how we think about health coverage and placing a number of restrictions around eligibility, particularly for Medicaid, but also impacting coverage on the individual market that we won't speak in detail to, but just want to highlight, the impacts to Medicaid aren't happening in a silo. We anticipate that hundreds of thousands of Medicaid eligible Washingtonians are going to be impacted by these eligibility provisions, some with additional burdens and barriers to accessing care, others who are going to lose access to health coverage entirely. We're still working with partners around the state. So this is a joint effort. HCA, as the single state Medicaid agency, has been leading a lot of the work to digest these federal requirements and think about how we are going to kind of move forward as a state. But we're not doing it alone, and want to emphasize a lot of the partners that we've been engaging with the Department of Social and Health Services, the Health Benefit Exchange, the Governor's Office, Department of Health, and obviously partners out in community as well, community organizations, provider groups, industry organizations that have really kind of stepped up to kind of help us navigate the next couple of years. So this is an overview of the different provisions, the major provisions impacting Medicaid that are in the budget. And again, just emphasizing this is not happening in a silo. There are a number of other provisions that were enacted this summer and other federal changes through regulatory guidance and rulemaking that are impacting Medicaid, but also SNAP programs, TANF, access to subsidies on the individual market, all of which are really targeted at the lowest income people across the country who really are in need of the social safety net to provide services and access. So here you can see kind of a cascading view of the major provisions that will impact Medicaid, starting with some restrictions that took effect immediately related to payment for reproductive services through our state Medicaid program, and then moving into a number of eligibility related changes that we'll speak to in more detail. We'll also spend a little bit of time on some of the payment restrictions that are occurring as a result of HR 1, but probably won't have a ton of time to get into detail there. This is just kind of another map of what that looks like in real time, kind of the flow of compliance over the next several years. And we've also overlaid here, you can see there's some additional provisions that we've highlighted in gray that speak to some of the other requirements that we're working towards that are outside of HR 1, but other federal changes that are occurring. So there's a lot of other work that's happening around the agency, and it's really to emphasize there's a lot of kind of corresponding impacts that will touch our programs, the services we offer, and eligibility for those programs. Starting with just kind of high level overview of state funding and enrollment impacts. Just acknowledging that work requirements and the increased frequency of redeterminations are going to have the biggest impact on eligibility and kind of coverage loss. But there's also some changes that are occurring to eligibility for lawfully present non-citizens that will see direct restrictions on access. In total, nearly 700,000 Washingtonians kind of directly impacted by these major eligibility provisions, over 600,000 who are in what we would term the kind of adult Medicaid expansion population, those adults aged 19 to 65 who gained access to Medicaid as part of the Affordable Care Act. They're really the target population of many of the eligibility restrictions that were put in effect in HR 1. And so those are the individuals that are going to be impacted by the work requirements, which have received quite a bit of press, but also the increased frequency of redeterminations. As I mentioned, there were some prohibitions that took effect immediately. Beginning July 4th of this year, there was a restriction on federal funding to Planned Parenthood and its affiliates, effectively a very focused restriction in the budget on Medicaid funding going to those services. The top line for us in Washington is that we've stepped up as a state and really with commitments from the state legislature and the governor's office to supplant the loss of federal funding with state funds, which means that Medicaid clients can continue to access services through Planned Parenthood in Washington and maintain access to family planning services as needed. But it's a restriction in federal funding coming into the state, and we know with our tight state budget that means something else isn't getting paid for as a result. A lot of interaction with the courts on this provision. It's kind of moved in and out of enforcement over the past couple of months. But for us, we've been able to maintain business as usual because of some of those political commitments that have been made as a result of budget. With that, I'm going to pass it over to Ari, who's going to talk in more detail about some of the eligibility provisions. And I should just again note, if you do have questions throughout, please do drop those in chat. We'll probably take them at a couple of places throughout the presentation.
Thanks, Evan. So one of the first Medicaid eligibility changes that is impacting Washington is related to changes in eligibility for non-citizens in Washington or across the country. Um, Effective October 1 of next year, Medicaid eligibility for refugees, asylees, and other non-citizen adults is uh, decreased. We think that about 30,000 individuals are impacted. However, they could be eligible for other programs, including Apple Health Expansion, which is the state-funded program, the 1332 waiver on the exchange, that's to purchase a insurance package, emergency medical or AEM, and then pregnancy or after pregnancy coverage. Noting here a couple of things. One is that children will continue to be eligible for coverage, regardless of their immigration status. And with the change, one group that remains eligible for fully funded Medicaid are Compact of Free Association or COFA Islanders. And that is like one of three that was specifically called out. The next large provision that impacts a lot of people in Washington are the work requirements. So this comes at the end of 2026, and this institutes work requirements as a new condition of eligibility for, again, that Apple Health for adults or the expanded adult population. Those are adults age 19 to 65 and who apply through Washington Health Plan Finder. They have to either work, train, do community engagement, volunteer for at least 80 hours a month, or have like an income minimum of $580. There are people who could be exempt, and we're looking at those populations, and we'll show some exemptions in the next couple slides. The impacts here. So one thing to note is that most people on Apple Health already work. But this could mean that folks could lose coverage. We think that more than 620,000 people could be at risk of either losing or delaying coverage because they have to verify a work requirement. There is the option to apply for a good faith waiver to delay implementation. And we're still waiting for guidance from CMS to see how we can go about doing that. Exemption. So there is a large list here that includes people who are pregnant or receiving postpartum coverage, people who are under the age of 19, foster youth or former foster youth under the age of 26. That's also known as alumni coverage. Tribal members, medically frail. This is a definition we're working on as it's applied, was created in the Affordable Care Act for states who did not elect the expansion adult population, disabled veterans, people who are entitled to Medicare, folks who are already compliant with work requirements for the Temporary Assistance for Needy Families, TANF, or the Supplemental Nutrition Assistance Program, or SNAP. Parents or caregivers of a dependent child under the age of 14, or parents or caregivers of an individual with a disability, regardless of age. Incarcerated individuals, recently released or within the past 90 days, and then those that are receiving AUD or SUD treatment. The other provision that kind of goes together with the work requirements, it has the same effective date, is increasing the frequency of eligibility redeterminations. So currently, when somebody has Apple Health for adults, their annual renewal, every time they have to redetermine it is like every 12 months in most circumstances. This provision increases that time frame to once every 6 months. Again, this is the same impacted population, so about 620,000 people. When we think about the impacts to clients and your organizations, we think that while most people will continue to automatically renew every 6 months, there will be a portion of the population, probably about 15%, that will need like active management. So helping people submit the forms that are needed, helping them go through Washington Health Plan Finder to complete that redetermination.
I'm not going to spend a whole lot of time here. This is a bit of a transition slide into some of the um, cost related and financing related provisions in HR 1, but they are big and they're important to call out. So there are two changes in the bill that impact how we finance the state Medicaid system. One is provider taxes, which is a mechanism that we use in Washington and many other states utilize to draw down revenue from commercial insurers, but also from the Medicaid program by effectively taxing Medicaid managed care organizations, which draws in federal match that we can pull out to use for different purposes to finance the Medicaid program. There are some caps that were placed in the federal budget on the level of provider taxes, their percentages of net revenue at the provider level. That begin in 2028. But it's also important to note that there was part of that provision prohibits growth in provider taxes. So there's in effect today a prohibition on provider taxes increasing in the state. For us in Washington, that has a direct impact on a provider tax. The state legislature actually passed in 2025, right before the federal budget was enacted, what they termed the Medicaid Access Program, which would have been a provider tax that tax providers to draw in revenue to increase Medicaid reimbursement rates, particularly for primary care, behavioral health, certain outpatient specialty procedures. And we're unable to implement that because of the restrictions in HR 1. There were also prohibitions on what we call state-directed payments. These are payment mechanisms where states can direct increases in reimbursement for specific providers or specific services. We generally, particularly for Washington, we are a managed care state, so we make most of our payments in Medicaid to managed care organizations, capitated payments that they then structure in contracts with providers to pay providers. Directed payments are a mechanism where we can control as a state rate increases or rate floors for certain provider types. And we do leverage state-directed payments in Washington. The biggest of those is what we call our hospital safety net assessment. We have a couple of others, again, that are really directed at hospitals, but that have funneled significant volumes of funding out through our Medicaid program to providers, including an increase in 2014 to the safety net assessment that put our reimbursement rates in our Medicaid program well over Medicare levels. Once fully enforced, the state-directed payment prohibition will reduce Medicaid spending in Washington by around $1.5 billion per year to hospital systems. Again, that is funding that was increased, kind of appropriated by our state legislature. It leverages a tax on hospitals, draws that money down, gets federal match on that money as it's sent back out to hospital systems. It's a mechanism we've been utilizing to increase reimbursement in Washington, which will get retracted quite a bit. It doesn't go away. We're still able to make state-directed payments, but as was shown on the previous slide, those payments will get capped at 100% of Medicare levels. So that's looking at what the hospital's normal reimbursement is with the state-directed payment on top of that can't exceed Medicare. It's a slow ramp down. It's a 10% reduction in those state-directed payments beginning in 2028. So we won't feel these effects right away. It'll take quite a few years, especially until fully capped at Medicare levels. But rather significant, as you can see here. This is quite a bit of financing that we utilize to increase access in the Medicaid system. Cost sharing provisions. Ari, were you speaking to this one or me? I'm sorry,
Yeah.
I don't have the.
Yeah, it's okay. So this is another provision that impacts Apple Health for Adults, the expansion population, effective October of 2028, and it imposes cost sharing of up to $35 for many services. This forces out-of-pocket spending for individuals who may earn as little as $16,000 per year. So the expansion adults have an income limit in a percentage of the federal poverty level of up to 138%. this provision starts that group at 100%. So it's not folks with zero income, but it is folks with 100% of the federal poverty level. There are certain services that this says we cannot charge cost sharing, and that includes things like primary care, mental health, SUD, or services provided at FQHCs.
Thanks. So one of the opportunities in the budget, and this is probably the only one that we can latch onto, is rural health funding. And I imagine many of you may have heard about this as well. So the federal budget allocated $10 billion annually to states from 2026 to 2030. So $50 billion total. It's a 5-year program. The funding is designated for use by states to support rural health transformation projects with focus on care promotion, supporting providers, payment reform, investing in technology, investment in workforce. There was a state application process that occurred earlier this fall. Here at the Healthcare Authority, we were actually the lead agency for Washington State's application. We were working in partnership with a number of sister agencies led by the governor's office to facilitate the state's application. It was submitted, I want to say, I have willful amnesia now, in early November to CMS, and we are still awaiting approval. So every state had to apply. All 50 states did apply for funding. Each state is guaranteed, if its application is approved, at least $100 million per year across 5 years. That would be $500 million across the duration of the program. And that funding can exceed, kind of well exceed those levels based on some scoring rubrics that CMS has to follow. So quite a bit of the funding is discretionary, and we expect, the federal government to distribute that funding in a manner that's not necessarily proportional around the country. We are hopeful that we will be awarded funding, and if so, are hopeful that we will receive funding that exceeds $100 million per year, but we're still awaiting that confirmation. We should have confirmation about our award before the end of the calendar year. It's possible we don't know funding levels at that time. In our application, we focused on 6 what we're calling initiatives. These are kind of primary focus areas. Within each, there's a number of different activities that we've identified. And this was all facilitated through a broad request for information that we undertook earlier this fall in September. And we received over 300 written responses from providers, community organizations, different stakeholders around Washington State, eager to either participate in the rural transformation funding or where there were ideas for distributing those funds. Our 6 initiatives are focused in a couple of areas. So hospital services, investments in tribes, workforce investments, behavioral health investments, IT investments, and then prevention and care management. For this group, I'll highlight one of them included some projected funding for Project Echo with the goal of expanding the number of specialties that are offered in the Echo program and expanding some of the reach into rural communities. So just to give you a sense of kind of the flavor of where we were looking to invest. CMS was very clear that the funding can't be utilized. We know there's going to be a lot of loss of funding occurring, particularly for rural providers that are heavily reliant on Medicaid as a payer. When individuals lose coverage, that means they're no longer either accessing care, or when they go in to access care, particularly in emergency room settings, hospital settings, the payment doesn't flow with them. So we know there's a loss of funding that's going to occur in the delivery system. CMS was very directive that we can't use this money just to backfill providers. It was a heavy focus on IT investments, innovation, payment transformation. So you do see that come through in our application. All the materials for our application are posted online. Again, can make sure that you all have access to those if there's any questions about some of the detail that sits behind this. We should know more within the next month, though, if we're getting money and if we are, to what extent.
Okay, just some other Medicaid provisions for long-term services and supports. There is a change in the home equity limit, a reduction from our current limit of $1,097,000 down to $1 million flat effective January 1, 2028. Retroactive coverage is also being reduced for all Medicaid and CHIP enrollees. For Apple Health for adults, again, the most drastic change from 3 months down to 1 month prior to application. And then for all other Medicaid and CHIP applicants, it's 2 months instead of 3 months. That's effective January 1, 27, as well as changes in address verification processes for example, when we receive return mail and what we do with that.
Thanks. We might pause here for a second. That kind of gets us to the end of the detail we were presenting on related to HR1. We wanted to share a little bit of additional information about some of the data sharing that has been occurring and really has been reflected in some press related to Medicaid programs around the country, and particularly for Washington. So we have a couple of slides on that. But might pause and just see if there's any questions related to HR1. Happy to take those now. And folks are welcome to either drop it in chat or raise their hand. Take that too. I'll share, as everyone's formulating their thoughts if they have any. Again, a lot of work that we have to do as an agency, but I think we're trying to, as best we can, humanize the impacts of all of these provisions and really reflect on how this is going to make what was already a very complex system for individuals to navigate harder. And so while we hope that few people will actually lose coverage as a result of these provisions, like we are doing everything we can to mitigate that coverage loss and building programs and policies to do that. We know that it's still a burden on individuals and, every bit of time that it takes somebody out of their day to dig up a document, engage an employer, talk to a provider about meeting an exemption just so they can stay enrolled in health coverage. And having to do that on a more frequent basis is time that they're not spending on the rest of their lives, which can be constrained as it is. So we're just trying to kind of stay connected to that and figure out how can we be creative as a state in mitigating some of that loss of coverage. And that includes a lot of partnerships. So just want to encourage everybody on the call, stay connected. We don't have the capacity really to outreach to everybody, but we do have a number of programs that providers and community partners can connect into our assister and navigator programs, building out an ambassador program again that we utilized during COVID to just kind of share information, make sure that anybody who wants it or needs it has access to communication tools, has access to the right resources, is able to help navigate someone who might not be enrolled in health insurance or looking for health insurance to our websites or the people that can help them move through that enrollment process, and just keep the state informed as we kind of go about implementation. So just encourage you all to stay connected. There's a lot of information that we'll be rolling out as an agency and a lot of ways to stay connected and support your communities as we move through implementation. And thanks, sorry for dropping some of those links in the chat. I also put in there some additional information on our rural transformation work. Okay, with that, not seeing any other questions, I'm just going to jump into data privacy. I'm not going to spend a lot of time here, but we, again, just want to acknowledge this is another area that's creating a lot of anxiety for folks who are accessing Medicaid coverage or looking to access Medicaid coverage. We want to emphasize at the outset, we're really committed to protecting everyone's health information. We house quite a bit as a state agency, obviously, from enrollment to claims data. But we do our best to avoid sharing that information wherever possible. By law, we're required to send certain information, though, on Apple Health clients, really our Medicaid clients, to CMS. So whenever there's federal funding attached to something, we do want to be transparent that that is information that we are required to share with our federal partners for program integrity and oversight purposes. Historically, that has been a partnership that we have maintained with the federal government, and there are a number of state and federal legal protections for how data is utilized and shared related to Medicaid programs. And recently, we have seen some significant changes to how the federal government is looking at that information. And we know that that's causing a lot of anxiety in communities. There are a lot of questions that have come to us, particularly about if individuals' information has been shared with a federal agency and how they might be able to utilize that. We obviously can't speak to all the specifics in many instances, and particularly when some of the first press rolled out on this earlier this summer, we were as blind to what was occurring at the federal level as everyone else was in the state and around the country. But we have worked to ensure the information we're sharing with our federal partners is only the information that is required to be shared, and nothing more, to ensure that we're not inadvertently providing personally identifiable health information to the federal government when it might not be necessary, particularly for things like state-run programs that we administer. So I just want to share a bit of information there, just acknowledging there's a lot that's occurring in the data privacy space. There are certainly some restrictions on how much we can protect information, and that's really based on the nature of the Medicaid program being a federal and state partnership with a significant volume of federal funding coming in to support coverage. But an area that we have been scrutinizing in an agency and taking a deeper look into, how we protect information and house information. With that, I think Ari was going to wrap us with a little bit of detail on just how to apply for coverage and just remind folks how to navigate the system. So.
Yeah. So currently we have a bifurcated system. So for folks that are under the age of 64, or a parent caretaker, pregnant, or applying for someone who's pregnant, Washington Health Plan Finder is the way to go. This is an online application with real-time eligibility results. If you go back to the slide with the timeline, there is a note that in one of the gray boxes, we're starting to, in the middle of 2027, move the classic program. So for those that are over age 65, over to this application pathway. But until then, we have the two applications. So there's an online, we still have a mobile app there. Everybody can call or submit a paper application, or we have local enrollment assistance through the exchanges LeadOrg and volunteer sisters throughout the state. The second pathway, again, is for those that are age 65 and older, are blind or disabled, or need long-term services and supports. That's through our sister agency, Department of Social and Health Services, and their online application, Washington Connection. There's, again, an online pathway, a paper application, a phone number, and folks who want to apply in person can apply through the Community Services Office for ABD coverage, or Home and Community Services for long-term services and supports. Just a couple slides on managed care or those without managed care. Washington is a managed care state, so we have 5 managed care organizations that provide care throughout the state. They help coordinate physical health, mental health, substance use disorder treatment services, and provide whole person care. Individuals with a managed care plan must see providers who are in that plan's provider network. They can change plans anytime they want. And for folks that are under age 65, that's done through Washington Health Plan Finder. Apple Health without a managed care or fee for service, that is when Apple Health pays the provider directly. Individuals can choose any provider that participates in the fee for service program and currently accepts patients. We pay in directly providers that provide inpatient psychiatric care, maternity support, dental care, and more. most individuals are automatically enrolled in managed care. And again, like I said, can choose the plan which best fits their needs. I think that's it for us.